Good evening, everyone. Welcome to our 26th Blue Earth Virtual Seminar. The Blue Earth Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Earth Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And as always, I'm your host, Adam Getachew. I'm the co-founder and CTO at Blue Health Ethiopia. And it's a huge pleasure for us to have Dr. Tilahun Jiru here with us. And he's going to give us an update on the approach to poisoning or general management of poisoned patients. And Dr. Tilahun is an assistant professor of emergency medicine and critical care.
Thank you so much. May I know the number of participants?
Yeah, 139.
Wow.
And
thank
growing.
you so much.
Yeah.
So, እንዴት ከረማችሁ? እንዴት አመሻችሁ? My name is Tilahun Jiru. I'm emergency medicine and critical care specialist, currently working at the level of an assistant professor at Addis Ababa University Rambasa Specialist Hospital. ይሰማል አይደል?
በደንብ ይሰማል።
በጣም ጥሩ. All right. So I'm really thankful for the Blue Health team for inviting me, and thank you so much. So after saying this, I think I can proceed to my presentations. So today we'll try to cover and discuss general management of poison patients. So this is my outline. We'll discuss the introduction and also general management principle of poison patient, and then if you have time also we can see some specific poisoning. So hopefully we can finish on time. So let's go to the next slide. So general information. So as we know, all chemicals have the potential to be poisonous if given at a large dose. So this is one of the things I have to emphasize because all the medications, including antibiotics, other cardiac medication, antihypertensive medication that can be given for a patient for a therapeutic reason can be consumed at a large dose because of intention of suicide, and that can also cause life-threatening conditions. And regarding poisoning is currently becoming a worldwide problem that consumes not only healthcare resource, but it also causes a premature death because most of the age group which is usually tend to commit suicide is in the age of 20 to 45, which is a reproductive age. So it is becoming currently it's a very great health burden, causing health burden and consuming a lot of costs. So poisoning occurs when exposure to substance adversely affect functions of any organ substance. So the exposure can be via ingestion, which is the most common route, and then inhalation and subcutaneous, and also injections. And fortunately, 95% of the episodes is caused very minor or no effect, but the rest of 5% can cause to the level of hospital admission and also mortality, which is around 1 to 2% of hospitalized patients can die of due to poisoning. And so And it can also cause around 5%. Usually, of emergency medicine or emergency room visit, around 5% of the visit is due to poisoning. So it is not a very minute problem. It's becoming a huge burden, especially in developing countries. So as you can see from the picture, any substance can cause poison depending on the dose. So with epidemiology, as I tried to mention in the first slide, more than 2 million toxic exposure is reported in 2020. This is an American study. Overall, almost more than 50% is children, and 60% of fatality occurred usually in the age of 20 to 48. 49. So this epidemiology is also goes with other studies done in a local setup, being around almost most of our patients are under 30s, and the sex-wise also more than 50% are male. So poisoning is a third common cause of death in a study done from 1985 to 1995. And the fatalities are commonly due to carbon monoxide poisoning or injections of other medications like analgesics, sedatives, antipsychotics, and antidepressant, and also alcohol. But in our setup, this is study done in a Western population. But in our studies, most of the common cause of death are because of organophosphates, and others are clearly unknown. So overview of management approach. So we need to be systematic and consistent while evaluating and managing such patient. And so evaluation should start with high index of suspicion. Always, usually most of patients who commit suicide, they don't tend to tell the history of taking the medication. So always in the patient who present with change in mentation, found unconscious. Regarding the approach, the most important step is recognition. So if we recognize late, the damage would happen, and then by that time will be very difficult to salvage the patient. So the most important is early recognition of the poisoning. So that is the first step. And then we have to look for agents involved. So that's also the next, because the management depends on the agent that the patient took. So knowing the agent is also the next step. And then we have to assess for the severity and prediction of toxicity is very important, because there are patients who need to be admitted to ward, to ICU, and those who need to be observed and then discharged. So disposition depends on the severity, and so we have to assess the patient for severity and the possible complications. And the next is management of the case. So we'll go for the management. So regarding management of a patient who present with poisoning, so these are the steps that we need to follow. So first is provision of supportive care, and then prevention of poison observation and administration of antidotes and enhancement of elimination of the poisonous. So regarding supportive care, so this is the most important one, okay? Before even going to the next steps, we have to always consider giving supportive care, which includes securing the ABC of life and then subsequent follow-up and management. So regarding supportive care, always we have to follow ABCD of life. And so the first is protecting the airway and immobilizing cervical spine. So patients who present with poisoning presentation can range from just simple dyspepsia and vomiting to the range of coma. So patient can present with compromised airway. Patient can have multiple vomiting, and patient can aspirate and asphyxiate, and also can die because of hypoxia. So always the first step in management of poisons is securing and protecting the airway. So when we protect the airway, we can then proceed to the next step. And one thing we should not always forget is cervical immobilization. So in a patient who presented with poisoning, especially alcohol poisoning, when they are drunker, they can be on highways, and they can also sustain road traffic accidents, pedestrian injuries. So they can concomitantly also present with head injury and also cervical injury. So the priority should be always in immobilizing the cervix. Should not always consider poisoning, and you have to suspect that the patient can have also concomitant trauma. And after airway, we can proceed to increasing circulation and putting the patient on oxygen, putting the patient on a mechanical ventilator, depending on patient needs, is also sometimes a must, depending on patient condition. And following patient with a vital chain, a mental status chain, and pupillary size also very important. And ECG monitoring, cardiac monitoring, and also continuously following for the oxygenation and ventilation is also mandatory, because this patient can present with compromised airway and can have also problem with oxygenation, acid-base abnormality, which can result in different range of respiratory embarrassment. And securing IV line is also important, because this patient can have also be in shock and can have vomiting, and also because of different nature of the medications can have hypotensive effect. So this patient might need fluid, pressure, and so on. So securing IV line is also one of step. And ruling out also hypoglycemia is important, because patients who present with change in mentation coma, always the easy one to diagnose and also easy to treat is hypoglycemia. So always the patient who presented with change in mentation, and so hypoglycemia should be ruled out. And if there is low random blood sugar, we poisoning patient. So always we have to start with ABC of life, because these patients are at risk for airway and breathing circulation issues, because patient can be comatose, they can also vomit a lot, and patient can have airway obstruction, asphyxia, and patient can die of airway obstructions. So securing airway is always a priority. And breathing, because of the aspiration, patient can also develop aspiration pneumonia, and also non-cardiogenic pulmonary edema. So putting the patient on oxygen is also mandatory, depending on the patient's conditions. And circulation also, securing IV line is an important thing, because we might need to give medications, and also giving fluid and also other medications might be necessary, because patient can also present in cardiovascular collapse, and patient might need fluid and some inotropes. So after securing the ABC of life, we can go for other management. So maybe one thing I need to emphasize here is given patients during these are naloxone and Synedrot. So this medication can be given simultaneously while stabilizing of life. Naloxone is very important because despite patient being comatose and no respiratory effort, if we give naloxone before considering putting the patient on mechanical ventilator, we can prevent the complication related with mechanical ventilation, because naloxone is known for short-acting nature. So it usually expects the response within a few minutes, So always before securing the airway, before putting the patient on mechanical ventilator, if you suspect patient to have opioid poisoning, please consider giving naloxone, because it can not change the course of the disease. And atropine is also very important, specifically in our setup, because most of our patients are presented with organophosphate poisoning. So by just giving atropine, we can prevent the pulmonary edema, the bronchoria, and we can clear the airways. So atropine is also one of the most important, and as there is a cocktail. So antidote is a substance used to counteract the toxic action of the specified agent. So it is well known to reduce mortality, but unfortunately only 1% of the poisonous agent have antidotes. So because it is only few, we need to be familiar with those poisonous agents, because if we know the antidotes, we can change the course of a patient condition. So at least we have to know the specific antidotes. So antidotes work by preventing absorptions, and there are also those which act by neutralizing the poisonous itself, and those also there are also those which can antagonize the organ effect and also inhibit conversion to toxic metabolite. So there are different ways in which the antidote works. So I think clinical is not important, so we have to know the antidotes. So these are the few poisonous agents which has got an antidote. So the common one we need to know is for organophosphates as atropine, and also for carbamate we can use atropine, and for anti-TB specifically isoniazid, pyridoxine is antidote, and for TCA like amitriptyline, sodium bicarbonate is one of the most important management agent. So we have to always consider patient present in severe conditions. And maybe the other is snake bites. Snake antivenom is also antidote, and acetylcysteine is for acetaminophen. At least we have to know a few of the antidotes. So regarding resuscitation of patient who presented in arrest, and we have to prolong our cardiopulmonary resuscitation, because, as I said, epidemiologically, most of patients who present with poisoning epidemiologically age-wise is age from 20 to 40, but in our setup, usually most are below . So, prolonging CPR is important for patients who presented with poisoning because of patient epidemiology, which is usually the young patient with no medical comorbidities. So the chance of recovering this patient is high. So we need to prolong doing the resuscitations. So while resuscitating this patient, we have to also consider giving antidote if the poisonous agent have got an antidote. So consider antidote is important. Regarding cardiac arrhythmias, so arrhythmia is also common in some poisonous agents, especially those which has got an effect on sodium channel, specifically like TCA, like amitriptyline, and digoxin can cause different kind of arrhythmias. So managing arrhythmias is sometimes challenging, because while managing arrhythmia with anti-arrhythmia medications can cause another form of arrhythmia. So the general principle is anti-arrhythmic medications are not first-line medications to treat the arrhythmias. So if arrhythmia happens, so the first thing that we need to do is consider treating other possible correctable causes, like treating the hypoxia, treating metabolic complication, acid-base abnormalities, are one of the few principles that we need to follow. And depending on the poisonous agent, we can also consider giving antidotes, specifically for digoxin-related arrhythmias. We can give digoxin FAB and sodium bicarb for TCA cycles. So if arrhythmia happens because of this poison agent, we can consider giving additionally an antidote. Otherwise, for other arrhythmias, for arrhythmia caused by other poisonous agent, more of the general principle of management is just treating the underlying causes. So seizure can also happen in a patient who presented with seizure and a patient who presented with poisoning. So management principle of seizure in a poisoning patient is giving benzodiazepines, which are first-line medications, but specifically patient who present with INH poisoning, we can consider giving pyridoxine, which is a first-line medications. Otherwise, the seizure caused by INH usually is refractory to benzodiazepine, so consider giving pyridoxine. And so seizure can be also caused by metabolic complications because of the poisonous agent. So always we need to consider other metabolic abnormality, electrolyte abnormality, and try to rule out or rule in and then manage accordingly. And the second line medication is barbiturate. So if it is resistant to benzodiazepine, we can consider giving barbiturate. But regarding phenytoin, phenytoin is a first-line medication for seizures in other conditions, but specifically for a patient which is a seizure, poison-related seizure, is phenytoin has got no role other it can complicate. So it's better to avoid phenytoin. So after you resuscitate, after you secure the ABC of life, then the next step is look for the specific poisonous agent. So the thing we can do to clear out the poisonous agent is, we need to have good history and do also physical examination and follow some protocols, which we'll discuss in a few minutes. So history-wise, we need to obtain clear history. I know that it's always difficult to get a clear history from the patient because patient might not be willing because of their suicidal intentions, because of repercussions, judgment, and so on. So it's better to take time and talk to the patient in private conditions to get the clear drug, and also a number of exposed persons like carbon monoxide poisoning, organophosphate poisoning, and so on. You have to know the degree of poisoning and type of exposure, amount, dose, and the route. Also very important to predict the natural conditions of the poisoning. So, and the patient intent is also should be determined, because the patient who commits suicide by taking these poisonous, so these patients are very high risk. So we need to admit such patients and assess for underlying psychiatric conditions. So patient intention should be also identified. And if it is difficult to get the history from the patient self, so we need to proceed to the collateral history. We can try to get history from the family and also from any witness person or from AMT. And so we can check for the empty bottles, containers, and we can even check for the smell of the patient, unusual containers found close to the patient. And if if possible, also if there is suicidal note, some patient even wrote also suicide note before committing the suicide. So we have to look for. And the other very important thing is from my experience, I was fortunate to see a lot of poisoning patients with different range of presentation. And so one of the patients I found was patient who was found comatose early in the morning, and he was brought by family, and it was really very difficult to know which medication he took. So the thing we did was we try to talk detailed history, specifically since he was a young guy with no underlying psychiatric issue. Was very difficult to know the specific agent, but finally, after knowing that he was a pharmacist, we even reached to the pharmacy and we tried to know the medications which were available in the pharmacy during those time, and it was actually phenobarb that he took. So we can even go to this degree to get the type of medication that the patient took. And also the other very important thing is if patient has underlying medical conditions, especially those patients with seizure disorder, epilepsy, and also a psychiatric problem. Most likely these patients are on some type of medications. So knowing the type of medical conditions and also type of medication the patient has been taking also very important. And one time also I encountered a patient who presented in coma after taking phenobarb, which was taking for the seizures. So this history are very important. And physical examination should be also done thoroughly. We need to analyze the patient completely. And also we have to check for any object or substance type to the clothes, and we have to assess the general appearance of the patient, degree of mental status, agitation, confusion, and also of conditions. And skin exam is also sometimes very important, especially patient can present with bruising, which is kind of trauma, cyanosis, which is because of carbon monoxide poisoning, flashing, and so on. And eye exam for pupillary size, there are no conditions in which a patient can have pinpoint pupil specifically from opioid and organophosphate poisoning, and nystagmus, which is usually caused by PCP. And depending anyways on the pupillary size, we can have certain differential diagnosis. And other examination, there are some agent which can cause physiologic excitations. So these are anticholinergic, sympathomimetic, or hallucinogenic agents. And it can be also because of drug withdrawal. So this patient can present with physiologic excitation like being tachycardic, hypertensive, and also hyperthermic, and patient can be also agitated. So in a patient with this condition, you need to have certain differential diagnosis like anticholinergic and also those differential I mentioned. And some patients can also present in a depressive mood, like with low respiratory rate, low blood pressure, and low mental status. So these are due to cholinergic, sympatholytic, opioid, and sedative hypnotic agent, and alcohols. And there are also agents that can cause mixed states. So sometimes it's really very difficult to know specific agent by just history and physical examinations. So one thing we can still narrow down our differential diagnosis is by following toxidromes. These are the toxidromes like cholinergic, hallucinogenic, and hypoglycemic. So what does toxidrome mean? So toxidrome is certain class of medication have a common sign and symptoms. So depending on this specific sign and symptoms, we can narrow down our class of medications. So recognizing the presence of toxidrome may help to narrow our differential diagnosis and to identify the toxins. So these are as I mentioned previously, anticholinergic, which can present with tachycardia, hypertension, and so on, and cholinergic hallucination. So depending on this toxidrome, we can narrow our differential diagnosis. And after narrowing our differential diagnosis, we can, in certain conditions, we can send for toxicological screening. But unfortunately, only few of poisonous agents have a screening tool. So it is really very limited and does not contribute significantly, but it may play a role in evaluation of children also, and also in certain other conditions, especially the patient who presented with phenobor poisoning, salicylate poisoning, and paracetamol acetaminophen poisoning. Sending for toxic screen is very important. So for undifferentiated and severe poisoning, sometimes it's better to send for acetaminophen and salicylate level determinations next. So only few medications can be assessed by sending serum levels. So these are few, like phenobarb, acetaminophen, digoxin, phenytoin, carbamazine. Most of anticonvulsant have serum level determinations. So one of the scenario I can mention here is there was, as I mentioned previously, there was a patient presented with coma, and it was really very difficult initially to know whether the coma is because of meningitis, whether it is because of poisoning or trauma, because patient she was found unconscious in her room. So when we assess for her underlying medical conditions, we were told that she was taking phenobarb for seizure. And then we suspected phenobarb poisoning, and then sent for serum level, and it was really very high, and then we considered dialysis. And after a few sessions of dialysis, she was awake and discharged after a few weeks, and then staying in the hospital. So especially phenobarb is one of the medications which we send for a serum level, because the diagnosis is also very easy, and the management, if you get the patient early and give him the few sessions of dialysis, the outcome is really rewarding. So serum level is also very important. Then decontaminations. So, and practically, we usually tend to give a priority for decontaminations instead of securing ABC of life. But the priorities for ABC of life, decontamination has really got few advantages, especially the GI decontamination. We'll discuss it later. So decontamination can be from cutaneous decontamination or from GI decontamination. So generally, decontamination is achieved by undressing the patient and washing the patient thoroughly with copious amount of water. So this thing should happen outside of its ED to prevent cross-contamination with other patients and also staff. So this should be happen in an isolated area, because these poisonous agents are also hazardous, and should be also put in a specified box and should be discarded, and patients should be initially in an isolated area. So regarding eye decontaminations, so eye can be also affected by certain chemical injuries. So especially alkalis are terminated to cause a significant eye injury, because as we know, alkali can cause liquefied necrosis, so it can cause deep injury. So always when you encounter such patient, we need to irrigate copiously with around 2 liters of NS. It can even take up to 1 hour. So we have to irrigate thoroughly for prolonged time, so that we can prevent the damage. So since the patient usually complain pain, now applying topical tetracaine local anesthetics is very important to make the patient comfortable and to thoroughly irrigate. And specifically for alkali injury, we have to communicate for ophthalmologic consultation because the degree of injury is very high in alkali exposure. So we have to have ophthalmologic consultation specifically for alkali. And when to stop irrigations in ideal setup, we have to have conjunctival pH. So we stop usually if the pH is less than 7.5. So regarding GI contaminations, so there are 3 general methods involving removing the toxins. So one is from stomach via mouth, like vomiting or lavage, and the other is by binding it inside the gut lumen to prevent absorption. And the third is mechanically flushing it through GI tract. So each method has got benefit and risks. So the first is gastric emptying via emesis. So emesis, as we know, it is inducing a vomiting. So this is done usually by giving a syrup of ipecac. So it can be, the dose is around 50 ml. So usually within 20 minutes, we expect vomiting. And so there are associated complications like patient cannot develop aspirations, Boyer-based intramallory waste air, and intractable vomiting. But generally, this is no longer recommended because when we compare the risk and benefit, the risk outweighs the benefit. So it is always better to avoid giving this syrup of ipecac because there's no mortality benefits. And gastric emptying. So gastric emptying is by inserting any tube and then flashing with normal saline. So when we insert, we have to use larger size any tube reaching up to 40 French, and in children it can reach up to 24. So we have to use the largest one. So we lavage it with room temperature water until the content become clear. Usually this is indicated with 1 hour of ingestion, and we can also use the energy tube for to give or administer a charcoal. So we should not remove the energy tube because it has got additional benefit. So orogastric lavage has got also certain contraindications. If it is large pills, so it's very difficult to remove large pills. So it's better to avoid. And if we are sure that it is non-toxic ingestion, by just inserting any tube and doing lavage, it can cause more harm than benefit. So if you are sure that it is non-toxic, it's better to avoid. And life-threatening also the same. If it is caustic injection, it is also better to avoid because when we do lavage, we can cause a second injury. So caustic injection is one of the contraindication for lavaging. And a patient with compromised airway, especially patient with low GCS in which no patient is unable to protect the airway, it is better to avoid lavage because that can cause aspiration, that can cause hypoxia, and patient can die of type 1 respiratory failure. So it is better. And hydrocarbon is also one of the contraindications because when we lavage, patient who took hydrocarbon, that can cause injuries to airways. So it's better to avoid. So there are certain complications while doing lavage. Patient can develop massive aspiration and also esophageal or gastric perforation, insertion into trachea. So these are few complications. So we have to always be cautious. And the drug removal range from 35 to 56. So the next is activated charcoal. So charcoal is one of the few decontaminant which is strongly recommended. It is most appropriate agent to decontaminate GI tract. Of all the decontaminant, the most important one is charcoal because it absorbs toxin in gut lumen and prevents reabsorption into the system. So the benefit is we can decontaminate without requiring invasive procedures like dialysis. So it is safe both in adults and the children, and the dose is 1 gram per kg. And there are certain contraindications for activated charcoal. One is if a patient is anticipated not to protect the airway. That's one contraindication. And the other is esophageal or gastric perforation if suspected. So it's better to avoid, because that's got also complications. And complications is the same with that of NG2 lavage, like patient can develop aspiration or also impaction is possible. And indication wise, we don't do activated charcoal or give activated charcoal for all patients. There are certain medications which cannot be absorbed by charcoal. So these are like alcohol, heavy metals, hydrocarbons, and acid and alkali. So this poisonous agent cannot be absorbed. So there is no point of giving charcoal for those cases. And in certain cases, as I said, charcoal is usually given within 1 hour of taking the poisonous agent. So in certain drugs, we can give even after 1 hour of lapse. So these medications are phenobarb, carbamazepine, and sustained release product, because these medications are anticipated to stay in the GI for more than 1 hour, especially phenobarb, is thought to delay gastric emptying. So if we are able even to do charcoal after 1 hour, the chance of absorbing the drug is high. So we can do it even after 1 hour. And aspirin, it usually forms quales, and it causes a bezor. So we can still get it if we do it after 1 hour. So that's called multi-dose, and we can also repeat the dose after the first dose. Usually the first dose is sufficient, but in certain medications like aspirin, phenobarb, there is also a place of giving multi-dose charcoal. So whole bowel irrigations. So whole bowel irrigation is one of the decontaminant ways in which we can remove the drug from the GI. So this is by using polyethylene glycol, which induces diarrhea. So we have to large quantity mechanically via NG2. So this will mechanically forces the substance to exit via GI tract. So it will is thought to limit the toxin absorptions. So the common indications for whole bowel irrigations, especially for body packers, people tend to transport or transfer this abused substance by ingesting. So these body packers, what we usually do is we just irrigate the GI. If we try to remove it by doing endoscopy or by surgery, the chance of perforating the pack is very high likely. So if we perforate, the chance of patient dying from this poisonous agent is very high. So usually what we do is we just irrigate the bowel, we wait for the patient to defecate via the rectum, and that's how we tend to treat those patients. And other heavy metals and also iron, lithium can be also irrigated. So second to activated charcoal, the second most important one is whole bowel irrigation. That's thought to got a higher chance of removing the substance with less complications. So in the point is clearing the rectal effluent, and the contraindication is patient has preceding diarrhea, GI bleeding, perforation, absent bowel sound, or obstructions. We don't do whole bowel irrigations, and the complication patient can develop bloating, cramping, and rectal irritations. And sometimes also these patients can also develop frequent vomiting. So usually pre-medicate this patient with antiemetics. And after decontamination, the other options is enhanced eliminations. So we eliminate those medications already, those medications which are in the system. So decontamination is before absorption. So elimination is if the medication is already absorbed and it is in the system. So we can use certain procedures to eliminate. So these are alkalinization, acidification, forced diuresis, and hemodialysis. We'll see one by one. So alkalinization. So this is most effective for weak acid, primarily eliminated by renal tract. So for a patient who took weak acid, we can alkalinize the patient, and so this alkali can ionize the weak acid and prevent reabsorption from renal tubular cells. So this is one of the management options. So always we have to make sure that there is no hypokalemia before alkalinization, because hypokalemia can reduce the effectiveness of urinary alkalinization, and it can also even worsen the degree of hypokalemia, and the patient can develop cardiac arrest because of the hypokalemia. So we might tend to worsen the hypokalemia. So always you need to make sure that there is no hypokalemia, or if there is hypokalemia, we have to correct the low potassium before considering alkalinization. And the primary indication is for moderate and severe salicylate, so and phenobar. So these are few substances which we can consider alkalinization. So specifically salicylate and phenobar poisoning, we can alkalinize, and the outcome is really very good, especially if we are not in a setup where we can provide hemodialysis, so we can consider. So we can also consider for 2,4-D and also alcohol poisoning. And so this is alkalinization usually done by giving sodium bicarb at a dose of 1 to 2 milliequivalent per kg. So there are associated complications while we give sodium bicarb. One is worsening of the hypokalemia and also hypernatremia, fluid overload, metabolic alkalosis, and so on. So always when we administer such medication, we have to anticipate the complications and treat accordingly. So acidification of urine is for weak bases, but the bad thing about acidification of urine is usually the risk of acidification outweighs the benefits. So it is not recommended to acidify because the risk of rhabdomyolysis by acidifying the urine is very high, so it is no longer recommended. Forced diuresis is also not recommended by giving Lasix. The chance of removing the poisonous agent is very low. Rather, the patient can go into shock and acute kidney injury. So forced diuresis is also not advised. Hemodialysis is usually limited indications in poison patients. Only few medications are dialysable, so it has got certain indications. So one is the substance should have a low volume of distribution, and that has to have also low molecular weight and relatively low protein binding. So such substance can be dialyzed. Otherwise, if it doesn't fulfill this criteria, the advantage of doing hemodialysis is it will be futile. So there is no importance. So there are certain toxins which we can remove by dialysis. One is salicylate and alcohol, ethylene alcohol, lithium, theophylline, and phenobarb. These are the medication or toxins that can be dialyzed. So if you find such case, please consider referral for possible dialysis. So contraindication for hemodialysis, like low blood pressure. For infant, we don't do hemodialysis, and poor vascular access if there is significant coagulopathy. So these are few contraindications. All right, so disposition. As we said, most around 95% of patients who present with poisoning have minimal injuries. So this patient can be, discharged at home. So there are also few other patients, which needs ICU. So we have to be, familiar with those patients who needs to be dismissed from emergency or who should be admitted to ward or ICU. So this is based on the patient presentations, the poisonous agent which the patient took. So usually observation period of 4 to 6 hours for low predicted severity, or for moderate observed severity. For low, we can observe just for 4 to 6 and then discharge them from emergency. But for those with moderate toxicity, those patients should be admitted to intermediate ward, or should be also an emergency, followed for a few days, and if there is no complication, they can be discharged. But those patients with significant toxicity should be admitted to ICU. So all patients with intentional overdose, as we said, always we have to make sure that the patient, we have to identify whether the patient took the medication intentionally or not. So if it is because of suicidal attempt, before discharge, we have to risk stratify the patient. There is a score. So depending on that score, we have to require psychiatric assessment before discharge, because those patients with underlying psychiatric illness should be treated before considering discharge, because this patient after discharge can come with another attempt and they might even complete the suicide. So always make sure that psychiatric evaluation before discharge. So disposition wise, disposition to ICU. So and patient with this mentioned criteria should be admitted to ICU. One is a patient, if we are able to do ABG and the PCO2 is greater than 45, if the patient is retaining carbon dioxide, we need to admit to ICU, because this patient can develop type 2 respiratory failure. So this is one of the indications, and the other is need for emergency intubation if the patient is unable to protect the airway or needs ventilatory support. So that's one of the indication. And post-ingestion seizure, patient also develops seizure. That is not a good sign. So we need to admit the patient to ICU and observe. And if there is arrhythmia, whether it is non-sinus or any degree of block, and if there is hypotension and prolonged QRS, so these are few indications to consider admissions. I see. So is activated charcoal available in our setup? Truly speaking, we don't have activated charcoal in our hospital, but I've heard that there are few hospitals with toxic center and lead supposed. So that toxic center is using activated charcoal. Otherwise, we don't have charcoal in my hospital. Shall we? Yes, we can. I can give you the slide. So Sanya, is normal saline recommended for GI decontamination? Yes. So GI decontaminate ለማድረግ የምንጠቀመው is just crystalloid የትኛው መጠቀም እንችላለን. So normal saline can be used. How can we suspect GI perforation in a comatose poisoning patient? So GI perforation is a clinical diagnosis. So patient with GI perforation can present with abdominal distension and tenderness, rigidity, and so on. So if you find such patient, it is better not to not give lavage, and any GI procedure should be avoided. Rather, the patient is laparotomy. So especially those medications, especially patients who presented with acid poisoning, these patients are at risk for GI perforation. So always we need to suspect that the patient might develop GI perforation. So we need to avoid any GI procedure in this patient. How can we get quiz link? How to approach organophosphate poisoning when it's golden time for atropine. So organophosphate poisoning is really very rampant in our setup because of most of our farmers use organophosphate as a pesticide. So organophosphate poisoning, unfortunately, has got an antidote, which is an atropine. So atropine is one of the medications that we need to give while securing AVC of light, because it has short half-life and a short onset, so we can get an effect within few minutes, especially patients who presented with pulmonary edema, bronchoria, and bronchospasm. Please consider giving atropine. So atropine is both diagnostic and therapeutic, especially in a patient who presented with this SLH-B. If you give atropine and it is not responding, most likely the poisonous agent is organophosphate. So you have to consider giving more atropine. But if the secretion and everything clears away with just first dose of atropine, that is against organophosphate. Usually organophosphate poisoning signs and symptoms, usually it takes few minutes or like few doses of atropine before clearing. So it is both diagnostic and therapeutic. What will be the initial ventilatory setting for patient with poisoning? So for patient with who needs ventilatory support, so the setting should be standard, but still it depends on patient conditions. So we can use the mode which we are really comfortable with. I usually tend to use ventilator mode and tidal volume like 6 to 8 ml per kg, and PEEP I can start with 5, but if the patient has got significant pulmonary edema, I can escalate the PEEP as high as like 20. So this is the setting that we use. Any specific management for zinc phosphide poisoning? Zinc phosphide poisoning. Currently, have like I've been working in some rural hospitals for like 4 or 5 years, and I had a chance to see a loss of zinc phosphide poisoning. And fortunately, unfortunately, I only saved one patient. So this patient usually presented with sudden cardiovascular collapse. They came walking, talking, not in distress, but when we measure the blood pressure is usually very low, depending on the amount of the agent that they took. Only even one tap, I think 1/4 of the tap can kill the patient. So zinc phosphide is a killer. So management-wise, mostly we don't have antidotes, just more of supportive, but we can consider giving sodium bicarb and also magnesium, but these are more of case report. There is no clear evidence. Milk for poisoning. Yeah, so culturally we tend to give milk for poisonous agent, but there is no proven efficacy of giving milk. Rather, we might cause aspiration, so there is no strong recommendations. So milk, okay, what maximum dose of atropine? So maximum dose of atropine, there is no maximum dose of atropine. Sometimes we can even, hospital ውስጥ ያለውን atropine ሙሉ ልንጨርስ እንችላለን. Okay, so there is no maximum dose. We have to go till we clear pulmonary edema, so that is a target. So there is no maximum dose. What's the best management in patients who overdose with unknown pills? So as I said, most of the times it's really very difficult to clearly know which specific agent the patient took. So in those conditions, we have to try by taking history, physical examination, following the toxidrome, but still sometimes will be very difficult. So if it is unspecified, so we can just give supportive care, because most of these poisonous agents have got an antidote, and management is usually supportive. Can we use carbocysteine in place of N-acetylcysteine or acetaminophen? I have no experience with carbocysteine, so I cannot comment on that. Milk for consequence slide. Management of comatose patient with phenobarb poisoning where no antidote is available. So phenobarb has got no antidote. Rather, as I said, phenobarb is one of dialysable medication. So please don't forget to consider sending the patient for dialysis if you suspect phenobarb. And if you have also sodium bicarb, you can give sodium bicarb for urinary alkalization. What is the treatment modality for inhalational poisoning? So inhalational, it can be carbon monoxide, it can be also organophosphate. So it depends on the agent. So if it is carbon dioxide, the management is high flow oxygen, 100% oxygen. For organophosphate and others, it depends on the agent. So what's your comment on atropic dose escalation? So this is one of the controversial thing. So different book recommends different dose escalation, but what we need to agree on is we should not suddenly stop giving atropine, because that can cause rebound pulmonary edema. We might even lose a patient. So there are standard textbook recommendations, so maybe I can add atropine dosage escalations, and so you can see it. So there is continuous infusion dosage. I don't exactly remember, but it is from like 0.04 to 0.1 or 2 milligram per kg per hour. So I can maybe share that. So snake bite.
Let this be the last question, so we will not do that.
Management of paracetamol poisoning in a setup with no antidote. Yeah, so paracetamol poisoning, it is really becoming a problem, because everybody abuse paracetamol because it is an over-the-counter medication. So always we need to have high index of suspicion that the patient can develop liver injury. So usually patient with paracetamol present lately with fulminant liver injury. So you have to now monitor liver stats for at least few days. I think as
yeah. Thank you so much, doctor, for taking your time. I know the network was not fair for us, so we have to take the time of you and also our participants. Thank you again. We hope to see you in another setup with another topic in the future.
Yeah, I will be happy. I will be happy.
Thank you so much.
Thank you. Thank you too. Bye.
Have a good night.
Yes.